synapsing here, right? Okay, good. Oh, did you want to go over anything else in here? So we have cranial nerve 11, right? Nucleus, substantia gelatinosa. You know, we would know these. This pyramidal decussations. So these are corticospinal tract. Decussating, sorry. So what axons would be running straight through this and not decussating there? Right, good. All right. So what is this structure? Anterior limb, right? So why do we know that's anterior limb and not posterior? Right, so it looks like a sapphire, right? Also, we don't see anything below here, right? So we're pretty far forward. We don't see midbrain, we don't see anything. We're seeing the hypothalamus forming, right? So third ventricle, hypothalamus, we have a little pituitary stalk coming off. So this is definitely pretty far forward. So this would be the anterior limb. I don't know if you'll have done it yet. So what is this guy back here? Caudate, right? And if they asked it, they would probably ask it in lab, and I highly doubt they would make you be specific about if it's head, body, tail, all that stuff, because you just haven't really covered it. You'll do that when you do basic ganglia stuff. But they did cover it in lab, so structure-wise, they might ask you a question. I highly doubt they'd do it on a slide like this. Probably do it in lab and say, what is this? And you could just put caudate. Unless it says be specific, then, you know, I don't. So this guy back here, putamen, right? And then these are, okay. Alright, so that's it on that. Alright, so what is this structure?
Internal carotid.
Internal carotid, right, okay. And they don't, last year they held us accountable for like, if this is cavernous portion, if this is a straight portion. They're not doing that this year. So y'all just have to know that this is internal carotid, okay? And this is the cavernous portion. So what is this guy back here? Fourth ventricle, right? So it's pretty easy. Fourth ventricle, where are we at? We're in the pons, right? So what cranial nerves are descending here? Or not cranial nerves, but you know, like corticobulbar innervation to cranial nerve. Okay, so 7, 9, 10, 11, and 12, right? So basically everything below this level. So facial is here, but we're not all the way through the pons, right? So facial nucleus isn't just a flat nucleus that stays in this one location, right? It's a round structure, just like every column or nucleus you're ever going to see. So it's round. So at this point, we have some corticobulbar stuff that's already gone to our facial nucleus on this side, but we also have more that are going down to do more in the pons, and then we're going to go down. Okay? So get up. And they might ask you that. Okay. So what is back here? So these are the pyramids, right? So these are pyramids of the medulla. So what body signs would you see if you transected or had a lesion to this side? Right, so you lose motor function, right? So signs and symptoms, they want to see upper motor neuron signs. And if they say be specific, you can throw some down, like, so hypertonia, hyperreflexia, spasms, positive Babinski's. And you're going to see these going, what portion of the body are you going to see these in? Dude, I said it yet. No, so it's going to be contralateral, right? So it's contralateral, but it's going to be the whole body, right? So you're not going to just see it in the leg, you're not going to see it just in the arm. You're going to see the whole body, right? So all of the corticospinal tract is descending here, okay? That makes sense? Would you have deficits in breathing? So like, could you still be able to breathe and have trunk muscles, right? Yeah, because even though it's anterior corticospinal tract, it's bilaterally innervated, right? So we have the other side coming down to support it. Yeah.
What's the big round white thing in the middle?
This guy?
Yeah.
I'm pretty sure that's just artifact. Because these are, I mean, these are, it's not like a, I don't think
What's
it's.
supposed to be there, just a little central canal study?
It should be just a. I mean, it should be this big. It should be pretty little because these are hypoglossal nucleus like forming, and you can't really see them, but they're starting to form. Because this is, I mean, like you just haven't seen it yet. Like, I mean, I'll just have to show you a better slide. But this shouldn't be this big. This is probably just artifact, and you just can't see the stuff in here. But there should be like nucleus in there. But I mean, they're not going to ask you that. But yeah, it shouldn't be this ginormous. But it does have a hole. All right. Oh, sorry. So what would be back here, like over on this side? ALS, right? So just to do vascular zones real quick. So what is the medial vascular zone here? No, I meant like what supplies those? The medial portion. Medial zone. Did I say lateral? Paramedian branches are what? Vertebral artery, right? So it's vertebral at this level. Because we're in the medulla, right? So that comes, go back, but, so these are vertebral arteries, right? And a little bit lower, you would still see, you wouldn't see vertebral arteries, you would see also anterior spinal arteries supplying the lower, okay? And that's, they have one over vascular zones, but I highly doubt they would ask it, only for the fact that there's going to be a whole test over brainstem, so they kind of want to save those questions. All right. So what are we looking at here? Is this a CT, a T1, T2? T1, right? So how do we know it's T1? Okay. So big hint is this is the lateral ventricle underneath this corpus callosum. So this is kind of a darker shade, right? It's not bright. So this is also fluid, T1. So what is this right back here? Quadrimal cistern. Okay. So what body symptoms / signs would you see in a patient with a damage to this nucleus or lesion? So it'd be ipsilateral loss, right? Upper motor neuron sign. I mean, lower motor neuron signs, right? Because these are the nuclei, nerves coming out. So lower motor neuron signs, you're going to see what in a lower motor neuron sign? Facet,
Muscle wasting.
flaccid, fasciculation, atrophy. Okay. And then just the opposite. The way I taught a couple of my groups is that I remember upper motor neuron versus lower motor neuron by true and false. So it's like TRU and FAL. So U is for upper motor neurons, right? So they're all increased. So T is increased tone, R is increased reflexes, and U is upper motor. And then false is FAL, and it would be fasciculation, atrophy, lower motor neuron, okay? And if it's the opposite, I mean, if it's like hyporeflexia, well, obviously it's not hyper, so it's lower. Does that make sense?
Yeah.
How you get those? And once you write that and kind of say it a couple times, like you're just like, oh, atrophy, and lower motor, it's just... All right, so what are we looking at here? So what weight is this?
T2.
The T2, right? So bright, looks like a photo negative. So this is a T2, and what is T2 good for?
MS.
So demyelination, right? So what is CT used for? Right, fresh blood, acute trauma, broken bone, that type of stuff. T1 is kind of for anatomy, so they just probably have it so radiologists can get a chart more for it. Oh, did we get everything here? Oh, sorry. You can put I would put, because it says disease process. So the disease process is a demyelinated disease, so it's demyelination as a disease process, as opposed to what disease, was best seen here, because it needs to be like multiple sclerosis, Lou Gehrig's, and stuff like that. But I highly doubt they would ask you because y'all haven't covered demyelinations yet. But you have talked about demyelination as being T2, better with T2, so they might ask you a question about T2 weight. Okay. So structure, fourth ventricle, right? Lateral ventricle, corpus callosum. pons, cerebellum. That's pretty easy. Okay, so what is this? ALS, right? So this is ALS. It says, what order are these axons? Second, right? So they're second. So the first order are back here in the DRG, and they come, synapse, come across the anterior commissure, and then up, okay? And they're not decussating after this point, so they've already done their decussation. And then they're, we got that. And so where do they synapse? So it's lateral VPL, right? Okay. So this PCML back here, where's this PCML? At the end, not cortical, but in the thalamus, where is this going to synapse in the thalamus? It's contralateral VPL, right? These don't synapse in the same spot. Because this guy's going to come up to the medulla and decussate and then go to contralateral, okay? So just make sure you know your decussations. So what is the structure? Kind of what you wrote.
Atrium.
Atrium. Pretty easy. So what are we looking at here? This is the epidural hematoma, right?
Yeah. Middle meningeal.
Have you looked at subdurals? I mean, I know you talked about them, but have you looked at them in pictures?
Yeah.
Okay. So epidural hematomas, they have a really nice, like, distinct border. Okay. And they kind of look like. Remember how in physics, when we all took physics and it really didn't matter, and, you know, for MCAT. Well, you remember how they had like a biconvex disc for like lens fraction and stuff? That's pretty much what this looks like. It has a nice border where there's bump in between the dura and the bump. Right? Yeah. So what artery would be causing this?
Middle meningeal.
Middle meningeal, right? So what hole does middle meningeal come through? What frame?
Foramen valve. No.
Venosa.
It's venosa.
So whenever you saw a subdural hematoma, you're going to see, it's not going to be this distinct border. You're going to see a border, but it's going to be kind of like this. It kind of looks curvy and kind of, you know, just not pretty. And then you're going to see diffuse kind of spreading into other tissues type thing. I mean, if you go online and look at different pictures, you can completely tell the difference. So what is subdural hematoma? So bridging veins, right? So bridging veins, that's more like a shearing type thing. So somebody gets in a car wreck and hits their forehead and their brain shifts forward, and those bridging veins are really tiny and they're connecting, you know, the sinus with the subdura, or the arachnoid space, and so they're just tearing, just like that. And so it's filling that potential space in between those two layers, okay? Also, presentation for this, you know, kind of board stuff instead of just this class. But this person's going to present most of the time getting hit in the head, getting knocked out, and then being fine. Getting up and being conscious and walking around like, oh, my head kind of hurts, but, you know, I'm fine. And then a few, you know, 30 minutes to an hour later, they're like, oh, crap, and die, or, you know, have pretty bad problems. And it's because you got to think about how tough this dura is stuck up against this bone, right? So this is a peeling away of this dura that's stuck to this bone. So, and the middle meningeal artery is a pretty small artery. It's not like a ginormous thing. So it's a pretty low pressure system. So it's going to take a lot of time to build up that pressure enough to start tearing apart that dura, and to where, you know, so that's why they're going to start out fine and then progressively downhill. So where would you see like a subarachnoid hemorrhage?
All over.
So this is a hematoma. So a hematoma is like a collection of blood outside of a vessel. A hemorrhage is a bleed, right, into a space. So it's going to be a subarachnoid hemorrhage as opposed to hematoma. Okay. Also, that's due to like a berry aneurysm most of the time in the brain, and most of the time it's MCA just due to the anatomy. And they're going to present with the worst headache of their life. So it's sudden onset. They come in, they're like, oh my God, I'm having the worst headache of my life. It's killing me. Like, you know, that's what's going on with that. Okay.
How do you tell on this which way is anterior? I don't know.
Which way is anterior? I mean, you kind of just look at it. So this is, so what is this guy back here? This is a pons, right? It's kind of hard to see. But you can see how this cerebellum looks a little bit different than this adjacent structure. This is cortex, right? So this is the cerebellum in the back. Then you start